Good morning, health. Thank you for turning out this morning. I'm Sam Schifman. I'm the Chief Innovation Architect at VANTIQ, and we're here to talk about heroes and legends. So I wanted to introduce you to one of my heroes, Dr. Silver. Dr. Silver's not actually a medical doctor. He's a chemist who worked for 3M. And in 1968, he set out to make a glue that was going to be better than super glue. He wanted a glue that he could actually use in constructing airplanes. He worked on it pretty hard, and in the end, he ultimately completely failed. His glue did not stick permanently. It kind of held, but it didn't really work. So he moved on to other projects. And then in the early 70s, there was another guy, Arthur Fry. He was singing in a choir, and he needed to keep his bookmarks in place in his hymnal. And he remembered this substance that he'd heard about that Dr. Silver had worked on, and he realized, that could really help me. And that's how the sticky note was born. As we all know, healthcare runs on sticky notes. There are sticky notes all over the place, and none of us would function without it today. Why is that? Well, some people would say that that's because the people who design EHR interfaces suck, but I don't think that's actually the case. I think it's actually got to do with complexity of the system. In 2024, there was an estimated 56 billion credit card transactions in the U.S. Seems like a lot, right? But when you look at it, there are around 30 trillion cells in your body alone. And if that's not enough, there's also around 30 trillion bacteria and microorganisms running around inside you, right? That's just an order of magnitude bigger. Also, if you look at it, most credit card transactions are pretty much the same, right? You have a source account, a destination account, and an amount, right? In healthcare, it's not like that. Patient one could have one lab test at the beginning of the year and another lab test at the end of the year. The next patient next to them could have 100 lab tests in a month, right? The data is just much more sparse. And finally, outcomes in financial transactions, putting aside the crash of 2008, are relatively binary, right? Either you have the funds or you don't have the funds to do the transaction. In healthcare, outcomes are not binary. One patient suffering from terminal cancer could decide that they want to stay in the hospital and get every possible treatment possible, right? The next patient could decide that they want to go home and have palliative care at home. Neither of them is right or wrong. It's just the individuals have different preferences. So all of that complexity leads up to a real problem for us. Let's look at an example. Let's talk about patient discharge, right? It seems like a relatively simple thing, right? We're going to have a patient who we identify needs to go to a SNF for rehab. We're going to have to find a bed for them. We're going to have to order their meds, do a bunch of other things, get a cardiologist consult for this particular one. That's going to lead to some other things. Finally, we're going to be able to have the nurse clear them, and we're going to get an ambulance to take them to the SNF, right? All of this looks like a pretty straightforward workflow, right? We can model this relatively easily. But we have to remember here in healthcare, the patient right next to them in the next bed could have a completely different flow that they need to go through. Now, traditionally, the way we process automation in the world of computers is that we get together a team of experts, subject matter experts and process modeling experts, and they sit together and they understand the current process, and they talk about what the new process might look like. They talk about how to roll that out, right? This is not going to work for patient discharge, right? Why? Well, one, it takes too long, right? It's too expensive to have all those experts sitting down for each patient. If it takes them a month to come up with the process, the patient should already have been out the door. It doesn't handle all the exceptions very well. It's really, really hard to model all the possible different ways that the process could play out. And it doesn't learn over time, right? I mean, the issue, the struggle there is that you want it to get better over time. If in order to do that with traditional process modeling, you got to go back to those experts and have them redesign the process. What if we could do it completely differently? What if we could actually have a network of agents that are all talking to each other and are able to figure out what the process should look like almost instantaneously? Now, I'm not suggesting they run that process, but what they can do is they can tell us what that process should look like, and they can also monitor over time and show us how that process should change. I believe that this is possible today, and this is what we're working on. So why is it possible now? Why is this thing which we call adaptive automation possible today? Well, throughout the history of computers, we've really been trying to get deterministic systems. We want it to be so that when I put the same input in, I get the same output out. And if it doesn't do that, we call it a bug, and we beat the developers up for it, right? Computers are really the only thing in our world that operates that way, right? I mean, most things are not deterministic. Most things are based on chance. I mean, we can have a good philosophical argument about the deep reality of nature, but most things appear to work by chance. And I would argue that actually probabilistic systems are more powerful than deterministic systems. That is the magic which large language models have actually unlocked for us. I mean, large language models do a lot of things cool, but in my mind, the real thing that underlying them that's the magic is their ability to behave probabilistically, but weighted towards positive outcomes. So we know that they can give us close to what we want most of the time. And if we put those large language models at the heart of what we call an agent, right, they can actually do pretty remarkable things. But we do need some things in order to make it possible to have these kinds of systems in reality. So what do we need? We need a system, first, a platform that's reactive. And when I talk about reactive, I'm talking about the reactive manifesto that you can look up. Some people spent some time thinking about how software could work in the modern world and actually be effective in the modern world. And they came up with this principle that it really needs to be responsive. What does that mean? Well, that means that it needs to behave the same way today and the same way tomorrow. It needs to give you the feeling that it's continually working. In order to do that, it needs to be elastic. It needs to scale with load and adjust. And it also needs to be resilient. It needs to be built with failure in mind, the understanding that the system is going to break at various points, and it needs to be able to recover from that. In order to do all that, it needs to be built on a message-driven or event-driven backbone. It needs to be what we call asynchronous in nature. And I'll just say that, VANTIQ is a platform for doing just this. It was built from the ground up for that, and that's why I'm with VANTIQ. But it's providing us with that ability to reliably have all these agents talk to each other and perform at scale. We also need these systems to be able to learn. We need them to be able to adjust over time. This is an interesting problem, and we're doing some really interesting research into it at VANTIQ. I can't go into too many details just yet, but I think that what we're going to see is the ability for agents to really remember what they've done in the past and improve over time, which will be a significant leap forward for them. But most importantly, these systems need to build trust. Somebody said to me, and I unfortunately can't remember who it was, they said to me, healthcare isn't slow to adopt technology. It's that it can only adopt technology at the speed of trust. And I thought that was really interesting. We need these systems to be able to, over time, build trust. And we have learned how to build trust with non-deterministic systems, haven't we? I mean, if you think about it, each of you out there is a non-deterministic system. And I have no guarantee that you're not going to start throwing tomatoes at me. There is a non-zero probability that that's going to happen. But I can be relatively certain that that's not going to happen because it probably would have some adverse effects for you. So figuring out how we're going to do that, how we're going to build that trust with these agentic systems is what's going to unlock the ability for us really to have them help the clinician. And I think it's important to think about it that way. They're going to be helping the clinician. They're going to be suggesting these processes and allowing them to execute them a lot more efficiently. But it's not that they're going to replace the clinician. So what will adaptive automation enable? I think this is where I get really excited in what we can do in the possibilities of the future. First off, adaptive automation is going to allow the clinician to unlock all the information that's hidden behind research, behind clinical practice guidelines. It's going to help digest all of that and make it available for the clinician. It's also going to be able to take care of some of them, the processes that are, you might call them menial, but I think that they're super important that we don't have time to do today, right? Clinicians do not have time to call their patients every day to check in on them, but an agent could potentially do that. And what this is going to enable us in the long run is really to break down what I call the encounter barrier, right? So much of healthcare today really is about the visit between a patient and a doctor, right? But we know that what really drives people's health is what happens outside of that visit. What happens between the times that you see your doctor, those decisions that you make. The problem is that breaking that barrier requires that we also break what I call the Candy Crush problem, right? So things like Candy Crush, games like Candy Crush are incredibly addictive for the first little bit of time. But then over time, a lot of people drop off. We see the same thing whenever we try to do programs to keep people on their drugs, right? We see that we introduce a program and it works really, really well for the first 6 months. And then there's some drop off and then it works for that remaining for another year. And then after a year, it just completely drops off. What if we had adaptive solutions that could actually watch for those drop-offs and change the process automatically, customized to that particular individual? That's the kind of future that I think adaptive automation is going to bring to us and is going to allow us to really radically change healthcare. And that's the kind of thing that we're working on at VANTIQ. So thank you for stopping by today. I would love to talk to you a little bit more about adaptive automation and the kinds of things that we're doing at VANTIQ. Our booth is right over there in the corner if you want to stop by and chat with us. But thank you for coming to Health and listening to a little bit about my heroes, and enjoy the rest of the show.